Understanding the correlation of health state utilities. This presentation is based on our publication titled Evaluating the Correlations of Cost and Utility Parameters from Summary Statistics for Probabilistic Analysis in Economic Evaluations. I thank my co-authors. The SARS and R code for the examples can be found in the appendices of this article. There are several types of common correlations of elicited utilities for different health states. First, health utilities could be elicited from a general population using time trade-off or standard gamble methods. Some individuals may report higher or lower utilities for all or many health states than other individuals as a function of socioeconomic status, education, and comorbid health conditions. Therefore, positive correlations among different health states could be expected. Second, predicted utilities or utility decrements from a regression model. Some researchers used regression models to evaluate the effect of different variables, such as patients' characteristics, interventions, symptoms, and health conditions, on utilities. Correlations may exist between regression coefficients. Based on the results of the regression model, one can estimate the difference in the utility between two conditions, with versus without a health condition, or with versus without a treatment, after controlling other factors. Third, repeated utility measures. Researchers often use longitudinal studies with repeated measures to evaluate the impact of interventions on health-related quality of life, including health state utility. Utilities of an individual are measured several times, at baseline and again at different time points, with expected within individual correlation between the baseline utility and follow-up values. We performed an informal search to explore what is available about correlations between utility data in the published literature. Publications reporting the EQ5D5L values set for England and the United States did not report the correlations between EQ5D5L health states. We further reviewed 24 studies that were included in a review of disutility for hypoglycemia in diabetes. Only 2 studies reported the variance-covariance matrix of regression models in their appendices. In summary, most published studies did not report the correlations among health state utilities. I will illustrate how to incorporate the correlations of the coefficients in the linear regression model for utilities in example 3. We included 8 diabetic complications and obtained a subset of the variance-covariance matrix of utility decrements in 8 health states. We converted the covariance matrix to a correlation matrix. The correlation matrix is presented in Table 2. The correlation coefficient of utility decrement was -0.323 between the on dialysis and foot ulcer health states. The absolute values of all other correlation coefficients were less than 0.2. After obtaining the correlation matrix or covariance matrix, it is straightforward to generate the multivariate normal distribution data for utility decrements in different health states, so to capture correlations among utilities or utility decrements. Furthermore, we estimated the utility decrements given the baseline patient characteristics and joint health conditions, 2 or more conditions. In our other article, we introduced the method of implementing a univariate normal distribution from multiple regression coefficients. In the example 4, we show how to approximate the average correlation coefficients of utilities collected over time, from a study that uses the area under the utility curves method to estimate the Cowley. Hollingworth et al. Conducted a cost-effectiveness analysis alongside a randomized controlled trial that compared sertraline, an antidepressant, with placebo over a 12-week period for depression. Authors measured the EQ5D5L utilities at baseline, 2 weeks, 6 weeks and 12 weeks. Then, the Cowley over 12 weeks in each group were calculated from the following formula. Our goal is to incorporate the correlations between utilities in estimating the variance of Cowley, but not the exact correlation between two visits. Under the assumption of a common correlation coefficient among visits within each treatment group, we estimated that the common correlation coefficients among 4 utility measures were 0.55 and 0.66 for the sertraline and placebo groups, respectively. After incorporating the correlation among 4 follow-up visits, we estimated that the 95% confidence interval of incremental Cowley at 12 weeks was similar to the estimate from the observed data. However, when ignoring the correlations among 4 visits, the 95% confidence interval of the incremental Cowley was markedly narrower than the observed 95% confidence interval. Therefore, the uncertainty may be underestimated. Thank you.